Hello, this is Jeff Swenson. We'd like to discuss the sciatic nerve block at the popliteal fossa, especially review some points of anatomy. This is a two-dimensional drawing showing the popliteal fossa with the lateral side being on the right of the screen and the medial side being on the left of the screen. And we'd like to point out some important features of the anatomy of the popliteal fossa. You'll notice that the borders of the popliteal space are formed medially by a confluence of the semimembranosus semitendinosus muscle and laterally by the biceps femoris muscle. The anatomy of the popliteal space is dynamic in that it changes as we go from the popliteal crease to the apex of the popliteal space. At the level of the popliteal crease, the tibial nerve is immediately superficial to the popliteal artery. The peroneal nerve is a good bit more lateral, and these don't join until they reach the apex of the popliteal space. So there's a change in the relationship between the vessels and the nerves as we go from the crease to the apex. If we look at the apex of the popliteal space, we see that the relative positions of the artery, vein, and nerve are such that the most deep and medial structure is the popliteal artery, lateral and superficial to the artery is the popliteal vein, and lateral and superficial to the vein is the sciatic nerve, more proximally and more distally a bifurcation of the nerve into the tibial and peroneal nerves. If we look at a fresh cadaver dissection of the popliteal space, we see here that we have the semimembranosus semitendinosus medially, the biceps femoris laterally, in a vessel loop medial to the tibial nerve and peroneal nerve, we have the popliteal artery and popliteal vein. You'll notice a couple of things. Number one, this space is open. We have not done any dissection of any connective tissue here. We've simply opened up the connective tissue separating the biceps femoris and the semimembranosus semitendinosus. So there is not a fibrous sheath surrounding either the nerve or the vessels. And this is important to remember because it allows us, if we access the space between the semimembranosus semitendinosus and biceps femoris, to inject into this space without being in immediate contact with the nerve and still get a block. In fact, if we look at a dye injection of methylene blue into the compartment formed by the biceps femoris and semitendinosus muscles, we can see that from anywhere injecting into this space, we get a wide distribution of dye staining both nerves for a considerable distance. So this just reinforces the fact that this is indeed a compartment, and we no longer need to get an immediate proximity to the nerve to get a successful block. So here's semimembranosus semitendinosus medially, biceps femoris laterally, and we see a wide distribution of dye around the tibial and peroneal nerves extending from the bifurcation all the way up to the confluence where the sciatic nerve is from a single injection point. It's very important when we are performing ultrasound of the popliteal space to apply firm pressure with the transducer and also angle the transducer slightly caudad to achieve a more hyperechoic view of the nerve. If we look at these two pictures, on the left we have the transducer perpendicular to the long axis of the leg, and on the right we have the transducer angled caudad about 15 to 20 degrees. And in this view on the right, we get a much more hyperechoic view of the nerve. And so, unlike many other images, this is probably the most important feature of the image of the popliteal space is the need to angle the probe slightly caudad, and this principle is known as anisotropy. So if we image the popliteal space at the level of the crease, and you can see in the lower left inset picture the level that we have our transducer at to achieve this artist rendition. At this level, we see the tibial nerve immediately superficial to the popliteal artery, and the peroneal nerve is a good bit more lateral. You'll notice as we move up to the mid-popliteal fossa that we now see the popliteal vein superficial and lateral to the artery, and we see the tibial and peroneal nerves in close proximity to one another and superficial and lateral to the vessels. And as we move up still more proximal to the apex of the popliteal space, we see now a confluence of the tibial and peroneal nerves to form the sciatic nerve, and the relationship between the artery, vein, and nerve is maintained. That is, the popliteal artery is deep and medial, the popliteal vein superficial and lateral to the artery, and superficial and lateral to both of these vessels is the sciatic nerve. If we use this compartment approach again, we can insert our needle medial to the sciatic nerve, and once again I would highlight that there are lots of ways to do these blocks: in plane, out of plane, medial to the nerve, and others. This is just one example, but we can advance medial to the nerve and give small doses of local anesthetic. When we pass through the investing fascia and we are in the same compartment as the nerve, we get a characteristic spread. I would highlight that it often appears that the local anesthetic is only on the medial side of the nerve, but if we change the transducer position and move it more proximally, more often than not we see that we have gotten a circumferential spread of local anesthetic around the nerve. So here's an actual example. Before we go live with this, just to orient you, the left side of the screen is lateral, the right side of the screen is medial. We see the borders of the biceps femoris laterally and the semimembranosus, semitendinosus medially. This is the peroneal nerve, this is the tibial nerve, and down on the medial side of the screen we see the respectively the popliteal vein and popliteal artery. Our needle is going to be inserted on the medial third of the transducer so as not to come down immediately on top of the nerve. So the lower left inset picture shows you the relationship between what we see on the image and where we're going to insert our needle relative to the transducer. This is one of the benefits of an out-of-plane approach. We know that if the nerve is on the lateral third of the image, if we insert our needle on the medial third of the transducer, we're not going to be coming down right on top of the nerve. So here, as we go live, you will see that even though we are not in immediate proximity to the nerve, as we inject, we will get a nice distribution of local anesthetic throughout this space, and once again there is not a connective tissue or an enveloping fascia around the nerve and artery. This is an open space that can freely diffuse. We're going to loop this so you can see it one more time. Here's our injection, and you'll see local anesthetic spread medial, superficial, and deep. So that's a very nice illustration of this. Here's one more illustration where we have biceps femoris laterally, semimembranosus, semitendinosus medial, nerve, and our injection. Once again, you can see the relationship between our needle and the transducer. And as we inject our local anesthetic, you will see the nerve become more obvious because it's surrounded by hypoechoic local anesthetic. And you can observe the very, very easy distribution of local anesthetic throughout this space. So next time we'll give you some more examples of these injections and a few anatomic variations. Thank you.